Thank you guys for all coming to Grand Rounds for June. Today we have Dr. Bays talking to us about throwing mechanics and video motion analysis. Dr. Bays received his Bachelor's of Arts in Exercise Science from Keene University. He earned his Master of Science degree in Physical Therapy from Marymount University. And while he was there, he earned the Outstanding Master's Degree Student Award. He then earned his Doctor of Physical Therapy from Arcadia University in 2018. He received his certification in mechanical diagnosis and therapy of the spine from the McKenzie Institute and is a board-certified orthopedic clinical specialist through the American Board of Physical Therapy Specialties. He utilizes video analysis regularly in his clinical practice and has taught multiple courses on throwing and running mechanics, utilizing video motion analysis. Dr. Bays is the facility director at St. Luke's University, is a facility director at St. Luke's University Health Network, and he's also an instructor in the TDPT program at Arcadia University and is the assistant director of the St. Luke's University Health Network Orthopedic Residency. So, without further ado, I'll turn it over to Dr. Bays.
Pretty sure I got to update my resume after that. So thank you all for coming. This is a pretty specific interest of mine. I don't have any financial benefit from doing this, or relationships for that matter. I loved playing baseball as a kid. And I played up until my freshman year of college, pitched. So it was always an interest for me. Don't be surprised by the McKenzie certification because I really enjoy looking at the overhead athlete, more so the thrower, and even more so the pitcher. So today the hopes are that, you can look at these objectives, I'm not going to read them to you, but the hopes are that we can identify what the literature tells us are the normal mechanics of the pitching motion, not just the throwing motion. I've combined the two terms, but we're going to specifically look at pitching, overhand pitching. We did get a question if there was going to be any review of softball pitching mechanics, and I said, you don't want me doing that. We could do it, but that's not what we're going to cover. And then we're going to explore some of the big pathomechanics of the pitching cycle, big picture stuff. I don't profess to be a pitching coach. Okay, I leave that to the guys that are coaching the kids. Hopefully, they have a pretty good idea of what the normal cycle should look like. And I think if we catch these kids young, we can get them to change some of their mechanics so they don't develop those bad habits later and reduce the risk of injury. I mean, really, that's our focus. Obviously, when we see these kids and teenagers, and I've seen some, collegiate pitchers, we want to try and, obviously, they're coming to see us most likely because they have pain. So we're really trying to identify, if we can't figure it out in our exam, we really then need to turn to the mechanics and look at what they're doing mechanically. And the video gives us the ability to do that frame by frame, so we can really break it down to its core. I'll get into the equipment that we utilize, but just a little bit of a background. There's two other gentlemen that I'd like to thank for establishing what we have as the Dartfish system, which is the motion analysis equipment. So three of us got our big heads together and tried to identify what we could utilize from a video standpoint, not just for throwing, but the big ones that we wanted to look at were running and cycling. And the two other gentlemen are Jeff Hetrick and Eric Kennedy. So we got together, say 5 or 6 years ago, and really sought out the Dartfish. I think a couple of those two guys saw it at a running course or a cycling course, one or the other or both. And we looked into it and then purchased our first unit about 6 years ago. We've since upgraded the camera because what we found was it was good for cycling, good for running, not good enough though, and really not good enough for pitching because of the speed of the movement. So I'll hopefully give you kind of an idea of how we're utilizing the motion analysis. The video, unfortunately, I'll apologize now. Unfortunately, the video that I have, our software system, I can't pull it up on this computer. Steve has to record, and it's on one particular computer, and we couldn't get the actual Dartfish file. We just have a what do you call it, Steve? A movie file? So I can't stop it frame by frame. So I'm going to try my best to show you just some big picture stuff on, I think I have 4 different pictures, and I'll do my best to try and stop it. I'm not sure I'll be able to stop it exactly where I want to. The nice thing with the Dartfish system we have is it's 100 frames per second, so I can just sit there and go boom, 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 and it just really nicely will allow me to see each piece. So when you look at the throwing motion or pitching motion, you can look at it both ways, throwing or pitching. It's a coordinated sequence of body movements, and that's what we really need to understand. It's not the arm so much. The arm may hurt, but we got to start from the ground up. So it's that sequence of body movements and muscular forces that have the goal of achieving the high ball velocity. So how is that athlete going to impart that force on the ball? And it really starts from the windup. And that's really kind of where we need to start. Just a little bit of background. So again, there's this link between the body segments, okay? We need to maximize ground reaction forces. Every time you hit the ground, there's an equal and opposite reaction back up through the body. Did you ever try and see somebody throw from the air? They really are having a difficult time generating a lot of velocity. So that kind of gives you an analogy on what we're trying to talk about there. You need to create a stable proximal base. We talk about this with the shoulder all the time. You create that stable scapula to help with the distal mobility. But this is way down the line. So we're starting from the feet, working our way up and trying to maximize the velocity that's coming out of the ball from the hand. And maximize force development of the core and legs. The thoracolumbar fascia, that's part of the connection from the lower extremity to the upper extremity based on its connection from glute max to the lats. So there's your connection. As you'll see later, the lats are one of the big internal rotators on acceleration. So there's that connection. So not only are you trying to keep the pelvis stable as you're going through that motion, but really trying to impart that force out to the arm. This is where we come in. So it requires optimal anatomy, physiology, strength and flexibility, task-specific motor patterns, and mechanics. So our job really is to deal with primarily from here to here. Then we can start to dabble in this. If we don't have this, we can't get to here. To me, it's simple. If we don't have this other, and listen, I've videoed a lot of kids. I keep saying the word kids because that's primarily what we. And there are some kids I've seen that they shouldn't be thrown. They should not be thrown. It looks like it hurts and it doesn't hurt, but it's gonna hurt eventually. And then when you examine them, you realize that there's a lot of work to be done from a physiological standpoint that they need to develop to really ultimately affect the mechanics. The core and the legs produce more than 51 to 55% of the kinetic energy transferred to the hand. Well, that's really what we're trying to, really trying to do. How often do you get a pitcher or a thrower and they have shoulder pain? Your first step, obviously, is to look at their shoulder. Do we screen their lumbar spine? Do we screen their lower extremities? Well, there's probably a good chance you don't. Okay, we can just be honest. But I think that's where it's starting. So especially if they're a pitcher, I mean, you really should screen it. Make it a part of, make it a part of that screen. So when you have the breakdown in the kinetic chain, then this will start to occur. The big one that, it's real simple. You'll get a variation in motor control. As you'll see when we talk about the wind-up automatically sets the stable base. Okay, if you don't have a stable base, you're done. Everything else from there is probably going to fall apart. So start there. There's not a lot of injury that occurs there. It's going to occur after. But if they're not stable, when they get up on that one leg, they're going to fall apart the rest of the time. And that's where this catch-up phenomenon, they're trying to then play catch-up. If they don't have it early on, they're going to catch up. And the thing that's going to try and catch up is their arm. So they're going to have to really try and catch the arm up and impart a lot of force through the arm to maintain the ball velocity that they want. So think about, and that's pretty general, but think about it in that respect. Because if they fall apart early, they're going to try and catch up because they're trying to throw hard, and it's going to break down. On the distal segments, those are the ones that they may not have any pain in the back. We'll talk about some things that may cause back pain, but they're typically going to see you for elbow or shoulder pain, typically. So keep that in mind. I mean, we really got to start there. It's like starting from the ground up. Common sites of pathological deficits: core, legs, shoulder girdle. And when I talk about core and legs, you're really talking about just some flexibility issue, not more, or flexibility and strength issue, not so much that they're having pain there, but shoulder girdle is primarily where they're going to have the pain. And obviously the scapula is of major importance. When we look at the pitching cycle, as you'll find, there are 6 main phases, but there are these 8 key progressive positions that we like to look at. Trunk control, as I just talked about, over the stance leg. That's where it starts. Hand on top of the ball in the arm cocking phase. So if that's difficult for you to understand, I'm going to use this mouse. I meant to bring a ball and I forgot. So hand on top of the ball when they come back should be here. It shouldn't be here. That's what that means. It's a simple concept, but once they start to turn that over, we'll talk about what could happen. I was just thrown on the beach probably 3 weeks ago with my nephew, and that was the first thing he did was this, and he did not want to do this. And so he's 9, so I was just working with him. He probably thought I was crazy, but I'm like, no, Jack, we got to do it this way. So he definitely thinks I'm crazy anyway. But stride leg direction toward home plate. This is a big one. It's an easy thing to pick up, maybe not with the naked eye, but you should be able to look at it. It's an easy thing to pick up. We'll talk about it a little bit more. Control of lumbar lordosis and acceleration. We'll talk about that. Hips facing home plate. Are they facing home plate, or are they locked facing third base if it's a right-handed pitcher, or are they too opened up and they're facing first base if they're a right-handed pitcher? What are we looking at there? Arm cocking. This is hard to see depending on the view you want to get from a standpoint of video. You'd really have to look at them from either the back or almost the opposite side to see what their scapula is doing. This would probably be more identifiable from 3D. We're doing 2D. 3D will really pick up a little bit more and give you more kinematic and kinematic data. High elbow above the shoulder, that's what we're looking for. The lower the elbow is, we'll talk about what could happen there. And long axis rotation at ball release. So there are your 6 phases. So in some of the literature, you'll see it called stride. Most of the literature, you'll see it called stride. The second phase is wind up. Stride or early cocking, again, you'll see it referred to as both. It's either arm cocking or late cocking. We'll talk about each. I'll go through what each step entails: acceleration, deceleration, and then follow through. There's just a little schematic to try and give you an idea of what you're dealing with. And it is a fast motion. It's not a slow motion. So there's my boyhood idol, Nolan Ryan. He probably pitched. Yes, I am older than most of you in the firm, but he did pitch into his 40s consistently through 90s, high 90s, 100. And when I look back on it now, his mechanics were pretty flawless, and he was rarely injured. He had a good off season. He was one of the guys that really did his due diligence in the off season, from what I've read. But his mechanics were flawless. So for every for every phase I'm using him. So the windup, it begins with that initial movement. I like to call it, this is where the magic happens. So start here and build going forward. Begins with that initial movement and ends with the non-stance leg at its highest point. I know there's a baseball coach in here, right? So there's this thing that I'm hearing these kids, and I don't know why. I didn't see anything in the literature, but I didn't look that hard. A lot of them are pitching from the stretch in Little League. And I'm like, why? They think I'm crazy. I'm like, why are you pitching from the stretch? So the difference is, for those of you that don't know, the windup, you start facing, typically, you start facing the plate, and your windup comes, and again, the stretch is when, typically, when you see somebody do the stretch, somebody's on base, and you're afraid they're going to steal, and they're taking a lead. Well, in Little League, I don't think you're allowed to do that, right? And you can generate more potential energy in the windup. But now there's this movement, I guess. And again, I don't know why. Maybe you can elaborate. Am I right? Are you seeing more of that? So I don't understand. But more kids are pitching from the stretch. The first kid that did it to me, I'm like, what are you doing? I'm like, why are you pitching from the stretch? There's nobody. We're videoing you. He's like, well, I always pitch from the stretch. I'm like, are you a reliever? He's like, no. I'm like, you start? He's like, yes. I'm like, you don't pitch from the windup? No, he's like, well, this is how they taught me, and this is what they want me to do. I'm like, okay. So I don't know. I don't know the dynamics of it. I don't know, if they're trying to get the kids used to pitching that way when they get older, or if there's some reference to maybe decreasing the load on the arm. I don't know. We'll see. Trying to find out. This particular portion of the pitching cycle lasts about 0.5 to 1.3 seconds. Okay, so that's pretty fast, right? You have to maintain the balance in the stance leg. These are the particular muscles that help you do that. Isometric hip abductors, we all know that on that stance leg. Isometric quadriceps to maintain knee flexion. So their knee's going to be a little bit slightly bent. It's not going to be locked in extension. Eccentric and isometric hip extensors to control and maintain hip flexion over here, not here, right? You create a stable base for distal components of the kinetic chain. I will say that a million times if I don't say it once, okay? Shoulders align between home plate and second base. So this is, you start facing this way, and then all of a sudden you make this 90-degree turn. Now I'm facing home. Risk of injury is low, okay? There's minimal muscle activity. We're not getting hurt here, typically. But we could down the road. So start here. If it's good, you're a step ahead. When you're on that stance leg, also, don't just look at it as having that center of gravity over this leg, okay? That's what needs to be done. But you also, when you're looking at it from either with the naked eye or from video, is are they forward or back? Because then again, once that center of gravity falls out and they're off balance, something else is going to happen down the road, okay? So pathomechanics, again, I allude to it when I'm talking about normal, unstable base of support, weak hip abductors, knee extensors. Decreased hip abduction strength associated with posterior superior labral tears, that's in the literature, and increased shoulder workload. Again, that's that part down the road. The workload's going to get taken up somewhere. We'll talk about at acceleration and then at deceleration what's occurring at the bicep. From an eccentric load standpoint, which may put more added force on the superior labrum. Premature forward movement toward home. I have a video of this one. You can see it. When I slow it down, it's pretty close. You'd never be able to see it when you look at it just with the naked eye. But when I slow it down, I initially said, yeah, he's going forward too quick. But then when I slow it down, I'm not going to be able to slow it down for you, but I'll try. It really does look like he shifts back on that, but he's still got this leg way out in front to my liking. But again, we'll see. High hand placement, shoulders greater than 90 degrees of abduction. So typically, you want to keep things symmetrical as they start to move down the line. So you don't want it too high. There's Nolan again. So we're going stride and early cocking. This begins when the ball leaves the glove, okay, and then at that max height, the ball leaves the glove, and then it lands with the lead foot, okay. Center of gravity is lowered. So what you'll see in the video is when they come up to here, they'll then start to shift down. This knee will start to bend, and their center of gravity will start to go lower so they can start to propel forward. Responsible for proper positioning of the trunk and lower extremity for energy transfer. Glute max provides stability of the pelvis and trunk. So again, something else to look at. You know, how are they stability-wise from a core and a pelvic standpoint? Stride leg, hip externally rotates. Okay, so as they come down, that hip is going to externally rotate. That could be a problem if they don't have enough external rotation, or if they don't have it, or if they don't have enough, or if they have too much. Same thing with the stance leg, has to internally rotate. So again, are they stopping short on the stride because they don't have enough motion either in the stride leg or in the stance leg? Trunk uncoils and starts to rotate towards the target. The pelvis is going to rotate first, and then the upper trunk will rotate after. When you slow it down, you can start to see that coordination of movement. Some of them just do the whole thing, and they're done. You know, arms way out here, chest is out, and it's all then arm, shoulder, elbow. You'll see some of that exposure. Throwing shoulder initiates external rotation and horizontal abduction. So again, that's that ball down motion, and they start to horizontally abduct. Stride leg contact should be positioned towards the target or slightly closed. So if they're a right-handed pitcher, it should be going in line with their stance leg to the target when they land, or slightly turned in. If it's a right-handed pitcher, slightly turned in towards third base. Left-handed pitcher, same thing, slightly turned in to first base. Stride length, approximately 85% of the pitcher's height. Now, again, this is where you're going to come into contact with the pitching coach. If you want to change it, you better check with them. If you want to change it because they're having some kind of soft tissue restriction, or they've changed it and now you're adding, you've improved their motion and now you think they can stride further, then start to work on it. But sometimes I think the coaches will try and shorten the kids' stride length for various reasons. But make sure the interplay between you and the coach should be, once you get that person back to pitching, the interplay between you and the coach should be, you should have good communication, because you don't want to do something that may adversely affect the thrower, especially if, again, I don't profess to be a pitching coach, so I want to make sure that it's clear, this is why we're doing it. Is it okay that I do this? And hopefully they'll have enough of the knowledge. If they don't have anybody, then by all means, go at it. Approximately 50% of ball velocity is a result of the forces in the stride and the trunk. So pathomechanics. This is one of the things we talk about. The decreased hip internal rotation of the stance leg lead to early pelvic rotation. They're going to rotate that pelvis earlier because they don't have enough motion in their hip. You're going to steal motion somewhere. So you got to, what is it, pay Rob Paul to pay Peter or something like that. You're going to steal it somewhere, and then things are going to fall apart. Decreased hip external rotation of the stance leg. Again, we're talking about influencing that stride foot placement, the closed position. And again, it doesn't necessarily mean that their foot is too far in. It could also, or rotated in. It could also mean that they're not in line with the target and they're here. Okay? All that's going to do is lock their pelvis. Then they can't rotate. So what's going to rotate? Their upper trunk. It's going to lock that pelvis in. And then the shoulder's going to try and do all the work and play catch up. Open, I see this more than I see the closed. So they are opening up. We'll be able to see that on one of the videos. The foot's falling way out to the side, and what's that going to do to their pelvis? The pelvis is going to follow. Everything else is going to follow, and their arms way back here. Okay, and then, again, they got to play catch up. Short stride length is associated with a decrease in ball velocity. So, again, maybe to unload somebody's shoulder, you start that way. But again, know that it's going to decrease their ball velocity. How much external rotation does he have? Quite a bit, right? See his front foot? He's actually probably pretty straight, not even turned in a little bit. Arm cocking or leg cocking, what's normal? So the stride leg contact has to, the knee is going to be flexed, so they're going to work eccentrically to decelerate the knee and stabilize the leg, again, providing that stable base, because eventually all the weight's going to be loaded onto that stride leg. Pelvis and trunk rotate towards the target with subsequent lumbar extension. I don't have this video, but I'll give you a situation here. We can talk about it in the next slide, but I'll talk about it here. So we had a kid that we filmed. I had one, Jeff Hetrick evaluated him. He was referred to us for a video for, and that's another important thing. If somebody gets referred to you because you're going to video them, if you tend to get that, if you have that ability to have that equipment, don't just video them. Even though they came from another therapist, the therapist did a great job, obviously, because they're throwing again, but maybe they want to tweak it a little bit. You should definitely do an exam on them. You don't want to not do it and just get them up there and start throwing. And what we found with this kid was he didn't have, he's a senior in high school, and he didn't have a lot of external rotation, and he was apprehensive about external rotation. I don't recall, but I think Jeff got him back to 110 degrees or whatever. And this kid was a good pitcher. And he had a slap tear, I think. Pitched his whole senior season this year, did very well. But anyway, when we looked at him, we knew ahead of time he couldn't. He was apprehensive going into that position. And what we found was he was hyperextending his lumbar spine to get him further back so he could have more potential energy to go forward to increase his ball velocity. The arch, and I didn't pick it up. Jeff picked it up. I'm not going to take that credit. Jeff picked it up. He's like, look at his back, and that's what he was doing. He was able to pitch without a lot of pain. I think he just wanted to get through his senior year. I don't know finally if he had any pain during the season, but the latest I heard of his stats, it didn't seem like he had pain because he pitched pretty well. But there was a compensation because he was afraid to go back into, or he just couldn't control it, into a lot of external rotation. So eccentric contraction of the obliques to prevent excessive lumbar extension, because then they're going to that trunk is going to get ready to flex forward during acceleration. The throwing shoulder externally rotating and the elbow flexing as the shoulder reaches 90 degrees of abduction. Normal at this phase is between 90 and 110. If they're going higher than that, it's too much. If they're not coming up to 90, it's not enough. Because if they're not coming up, then they're going to probably come down here and throw sidearm. Scapula maximal retraction, lateral rotation, and posterior tilt. This is important to maintain the subacromial space. I'm not sure how you measure that. Get their shirt off or put them on in a tight shirt. And that's the other thing when we talk about the video. Get them in tight gear so you can see what's going on. If they got loose, floppy stuff, you're not going to be able to see it as well. Rotator cuff, long head of the bicep and the deltoid, give the humeral head the compression into the glenoid. And again, hand on top of the ball. We'll keep saying that because it's an easy thing to pick up and something that could be valuable down the chain. So some of it's, again, if you know normal, some of it's pretty self-explanatory. Early trunk rotation, talked about that already. Increased valgus torque on the throwing elbow. They're up here. Arms still back here, right? Abdominal oblique weakness, again, that's going to get them to go more into extension. So if you got somebody that comes in and they're a thrower and they don't have shoulder pain, but they have back pain, one of the things you're looking for is a spondylolysis, because these kids, that's probably what it's going to be, especially if they repetitively are going back into too much lumbar extension. GERD, glenohumeral internal rotation deficit, and what we like to follow more is that total rotational movement greater than 18 to 20 degrees increases the risk of shoulder and elbow surgery. The total rotational movement less than or greater than 5 degrees is what you don't want. So looking at that, increased shoulder external rotation associated with slap tears. Again, I don't know how to define that because that could just be my lack of knowledge. Increased shoulder external rotation. Again, normal is in a kid that's pitching a lot, you can probably bet you're going to see 130 to 175 degrees of external rotation if you measure it. So if they're more than that, that would explain why things are going on. But and you might get them further than that, but are they doing it while they're pitching? Scapular dyskinesis, again, that's the big one when you're talking about the shoulder. But again, why is that occurring? Is it something lower, or is it just the one kid I just told you about that shouldn't be throwing? His scapula was a mess. It was just a mess. And it had less to do with from his hips down than more about what was happening at his shoulder. And again, hand under or on the side of the ball increases the valgus strain on the elbow because it's going to automatically already put them in external rotation. So now they're already there and putting more load on that medial aspect of their elbow. Acceleration. So this occurs between maximum external rotation and ball release. So this is the other part where the magic starts to happen. So the trunk continues to rotate and moves from an extended to a forward flex position. So now that center of gravity is really starting to go forward. Greater muscle activity of the obliques, rectus, lumbar paraspinals on the non-throwing side to give them that stability. Serratus contributes to scapular protraction. This whole time, hopefully what I didn't mention at the beginning is trying to envision what's happening while they're pitching. That'll help you kind of get an idea of what's happening. But think about as that ball's coming forward, your scapula is going to protract. Right? Elbow initially flexes from 90 to 100 degrees, then rapidly extends. Optimal position of the throwing arm with a high elbow is with a high elbow at 90 degrees of abduction. So as they come through here, okay, again, you don't want it down here. You would want it shoulder height or just a little bit above, at least from the stuff that I've read. This particular phase constitutes between 42 to 58 milliseconds of the total sequence. Think you could see that with the naked eye? I don't think so. So it's one of the fastest human movements in sports activity, 9,000 degrees per second from maximal external rotation to rapid shoulder internal rotation, so as they release the ball. Amateur pitchers exhibit up to 3 times greater bicep and rotator cuff activity. The key is, some of the literature will tell you that the mechanics, if they're good early, will prevent injury later on, and there's not a big difference. The big difference is in the amount of force that's being exerted through the joints. So if their mechanics are good early on, you can do a lot of injury prevention just by trying to minimize how bad their mechanics will be. So some of the pathomechanics, lumbar hyperextension, I got a kid on the video, you'll see his hyperextension, increased stress on the posterior elements of the lumbar spine, that's obvious. Slow arm, the arm is behind the body with increased abduction and external rotation. Again, increases the compressive load on the shoulder. Throwing elbow drop below 90 increases the valgus load on the elbow. In this phase, in some of the reading that I was doing in prepping for this, they talked about lateral trunk rotation in this particular phase. And you're going to get a little bit of lateral trunk rotation, and that's good. What they found was the more you increase the lateral flexion of the trunk towards the stride leg, to a certain point, you can increase ball velocity. Problem is, it increases the load on the shoulder. So the same kid with the hyperextension, you'll be able to see his lateral trunk flexion. He really if he doesn't get hurt, I'll be surprised. But so they may be more inclined to do that because what they've realized is now they can generate more ball velocity. But let it be known that they're putting more load into that shoulder. All right. So the reason for this is one of two things. One is if you're a pitcher and you hit somebody with the ball, be prepared, they might come at you. But the deceleration phase is the most violent phase of the pitching cycle. So hence he won that fight, by the way. I'm proud of him. That was the biggest mistake Ventura made. So it is the most violent phase. It occurs between ball release and maximal shoulder internal rotation and elbow extension. It results in the greatest amount of joint loading during throwing. So there's an inferior shear and compressive force at that same time. The rotator cuff contraction and the posterior capsule help minimize, help limit that anterior translation. So if you think about it, if nothing stopped it, the shoulder would just go and keep going. So something's got to slow it down. And that is something that could be indicative of that repetitive trauma on the posterior aspect of the shoulder. Is one of the things they would contribute GERD to, because that repetitive micro trauma, trying to slow that arm down, slow it down, takes a huge amount of eccentric load on the cuff and big amount of load on the posterior capsule. Traps, serratus, and rhomboids help decelerate the shoulder girdle and stabilize the scapula. So pathomechanics, again, I just said this, and I'll have to say it again, it's that posterior aspect of the shoulder takes a beating. Most overuse injuries occur during deceleration, slap tears, rotator cuff injuries, bicep. The bicep, again, during deceleration, as the elbow goes from this 90 degrees, about 90 degrees, into extension to about 25 degrees of extension, is under a huge amount of eccentric load to slow the elbow down. So again, there could be an area that you'll see an overuse injury. Follow through, so the weight is transferred to the stride leg. The trunk decelerates, so you got another eccentric component, and it's flexed over the stride leg. One mistake I made early on, and I'm not so sure it was a mistake, but I particularly remember one kid that I filmed. I think I was right, but I'm not sure. When he landed, he never really flexed his knee, and he really kind of kept it straight, which to me blocked him. And it depends on where in the phase you see that, because eventually they're going to straighten that leg. Because as they come down, that leg goes from here, and it's going to start to straighten to make them a little bit more stable. If not, the knee would keep bending. So that's something that you really have to fiddle with. But this kid, he was an outfielder and a pitcher. I thought he was extending that knee too early, and then he couldn't lever over to generate force. He had shoulder pain. Not afraid to admit when I'm wrong either, so it's a good thing. Keep that in mind. Write that down, you youngsters. Trunk decelerates and is flexed over the stride leg. Shoulder horizontal adduction continues to 60 degrees, so that horizontal adduction across this way. Arm continues to decelerate. Phase ends with the pitcher in a fielding position. This one is hard for me to swallow because I don't see a lot of pitchers ending up like this, except for Greg Maddux. If anybody know who Greg Maddux is, he always ended up. A lot of them are falling off to the side. Do I fix that? Well, I think as long as they're close, that's fine. But in a fielding position to me is this way, and I don't see it all that much. So. This, the pathomechanics, the biggest one is if you abruptly stop the arm from going forward. I mean, that's really the bottom line. Rarely do I see it, and it's rarely, rarely brings up an injury for that person. It's usually going to happen way back when there's a lot more muscle activity going on. So evaluate, what do? You evaluate the shoulder. Okay, we got our, it's not for me to come up here and tell you how to do a shoulder exam. It's not why I'm here. You should do a thoracolumbar and a lower extremity screen. I think that's probably worth your time. You may want to go back after you look at the video and do it a little bit more in depth and see. But definitely, if you see the video and something's going on from the trunk down that you see, go back, because if you start to change things and you realize, why I'm telling him, I'm giving him this drill to do, change this, and he can't do it. Well, maybe he's got some type of limitation, range, strength that you're not changing. So you can do all you want. You probably end up making him worse if he can't get to what you want him to do. And then the video, it's a good tool. I like to use it. I'd like to use it more. Our camera's on the fritz right now. I gotta call Dartfish. Sorry, Jeff, if you're on the line. Haven't got to it yet. But something's not right with the camera. It's coming out blurry. But it's a great tool. So it really allows us to look at it frame by frame. It's not going to give you all the fancy data that you might want, but it's enough. So why do we want a video? The human. So I found this interesting. I didn't know these exact stats, but crucial movement in a pitcher's delivery takes place in 1 in 250th and 1 in 750th of a second. Okay, so those crucial moments, human naked eye processes images at 32 frames a second. So when you're trying to analyze the motion, you really should have something. I mean, phone cameras, 30 frames per second. Our Dartfish camera is 100. Okay, at 60, our camera will sometimes default to 60. At 60, it's still blurry when I try and slow it down. The resolution goes out the window, and if I don't get it to 100, it looks like crap because I can't. It's too fast. Can't stop it quick enough. So that's really what you're after. Some of the higher end ones, 240. I saw some even higher, a lot higher than that. So we don't have that, but when this is at 100 frames per second, it works very well. So 2D versus 3D, we do 2D. That's what we have. 3D requires multiple. You're getting multiple angles at the same time. Light-sensitive cameras, insanely expensive. Usually performed indoors, or used performed indoors. You're not going to be able to go portable. So that's not what we have. 2D is less expensive and it's easier to use. You can take a video on the phone. It works pretty well. There's a couple apps out there. Dartfish has an app. I think it's called Dartfish Express that you can utilize, and it'll give you some of the ability to slow down. But again, know that it's going to be a little bit slower. 2D at a little bit less resolution. But when they look at the two and compare the two in some of the literature, 2D versus 3D, when we look at variables of the pitching mechanics, their association, you're able to get it. You're able to get the big picture stuff that I think we need. I don't have a motion analysis lab that I can take a picture into. We do have a nice portable mound though, but that's as far as it goes. But you can get the information you need, and I think it's good for us, athletic trainers, the coaches. It's easy to use, easy to manipulate, easy to understand. So again, I think it's a valuable tool. You don't need all the bells and whistles. All right. So here's example number 1. This is the kid that now again, you're going to have to forgive me. Here comes Steve. I have it off. There we go. This is the kid I thought was forward. I'm used to seeing this leg come up through here because that tells me that some of his weight is over here. Am I going to change that? Probably not, but I could. See if I can get him any. So he's already starting to go forward. Now, when I was able to slow it down with the dartfish, I was able to take him back and forth through these segments. Back and forth. I just kept going back and forth, back and forth, back and forth. And it was close. So, and I think, you know, when you're that close, do you make that change? This kid doesn't have any pain. His mechanics weren't bad. But that was the thing. I'll let him go. I'll let you go through. So that's normal speed. I'll let it go through a couple times. If you just watch that without being able to slow it down, how are you going to get information? I think that's the problem. It's great to have this video, but if you can't slow it down. One other thing I want you guys to look at. Let me see if I can get it to stop. A couple things there, right? So for you over there in Cloudland, you can't see my pointer, but I can't go past this thing or I'm going to be out of the camera. Where's the pointer?
Use the green thing.
Or you can just do this.
I'm going out of the thing.
Dude, just do this. Do this. Use the mouse.
Oh, perfect. So look at his front foot. Which way is it facing? Right? Where his elbow is. Right? So he's already opened up. Foot's over here. Plus, not only is his foot over there, but it's not even in line unless the guy is standing on the first baseline. That's where he's throwing. That's not going to work. Right? How do we get to the next one, Steve? Just go next. All right. This guy had all sorts of. Coach, help me out here. Ready? Here we go. There's one thing I wanted to show you with this guy. One. Yeah. Straight up and down. That's one. He comes on. You know that talk about that ball down? He's probably yelling at me. See the ball? See the ball? Still not down. Now that might seem like a little thing, but if this kid's got elbow pain, that's something that's easy to change. Easy to change. Next one. Huh. Almost fell off the bucket. Like I said, there are some kids that shouldn't pitch. Now, this kid threw well, but he's going to get hurt. Right? Now, one of the things you look for when they're at max, he's not at max external rotation. But one thing you look for is when they're at max external rotation, there should be a backward C. You can see it better from the side. But I wanted to show you this because looking at his extension and his lateral trunk tilt to the other side, to that side. And he comes up way over the top. Division I player right here. I put him in here because he's pretty good. Oh, Steve. Just kidding. I got it. Steve gave me specific instructions and I'm not following them. Pretty stable, right? See the difference in his leg as opposed to that first kid, right? Again, I don't know if that makes a difference, but something to look at. Ended up in the fielding position. I think we saw that was his foot. I don't know how his foot came down. He did have shoulder pain. Again, this is not ideal because he was pretty good. It's not ideal because I don't have him on a mound, but we wanted to get him filmed. So it's a complex interaction of these body segments, and you got to put it all together. I think that's the beauty of it, and kind of the excitement about it. And as you could tell by my volume, I get very excited about it. Although my volume's loud anyway. Each segment contributes to increased velocity of subsequent segments. So if you mess up down here, you're not going to get what you want up here. Pitching motion is divided into 6 phases. Thorough understanding of normal will allow precise analysis of pathomechanics and improve rehab. If you don't know normal, you can't fix abnormal, right? So it's like that wound bed. If you don't know what the wound bed should look like, how are you going to know how to treat it, right? Valuable tool to reduce injury through development of injury prevention program. We need to utilize this more, I think. Coach, I'll film all your kids. Bring them over. Improved biomechanics equals less force and improved mechanical efficiency. I mean, that to me is very straightforward. If you can improve their biomechanics, doesn't have to be perfect, but if at least you can make it a little bit better, you can improve their efficiency. You'll probably get them to throw harder, which is what they want, and keep them healthy. Questions? I'm going to go ahead and him first. He beat you. Sorry.
So with the stride leg, when they lift the knee,
Mm-hmm.
are you opposed to having straight up or internal?
I like it coming in. I look at it as like a corkscrew. Like you wind up. I think you're developing more potential energy. That's what I always did. Not that that's right. I think you've got to have good stability because you're throwing that center of gravity a little bit more in that direction. So if you don't have if you can maintain stability, I think you do it. I could be wrong, but that would be my best educated guess.
Because a lot of them, when they lift, when they turn internally, they also turn their upper body.
Yeah, and I think back here, I think you're okay. But if you can't keep it stable, then keep them straight. Yeah.
Do you have a problem getting the kids to buy in with the changes you're trying to make on their?
If they're young, no. If they're older, yes. I mean, and then that's where I got to turn it over to the coach. Like I have some knowledge of some drills that we can teach the kids. An easy one is really, if they're falling off too far, put something where they have some feedback that they put a pole down. They can't step over that pole. Just something simple, but the older kids, it's harder. And that's why you got to get them young. We've talked about it. If you can get them younger and change it then, it's easier. They haven't developed that, that internal memory, that muscle memory that they're just going to keep doing it. So, and if they have a specific way they want to do it, it's going to be hard to change. Yeah. Yeah.
As far as talking about the younger kids, so on the 9 years, are you getting kids that young referred to for pain?
Oh, yeah. The kid I just had was 10.
Okay.
Had elbow pain. But he shouldn't be throwing. Shouldn't be pitching anyway. But we had, I have him on film, but I don't have him here. 11-year-old humeral avulsion fracture in his elbow. Kid threw hard, but he threw all arm. It happened. As soon as we got him on video, I'm like, oh my gosh, we got to do something there. It was, yeah. And they're being strict with the pitch counts, but it doesn't matter. It really doesn't matter. You can pitch 20 times, and then if you're not doing it right, it's going to hurt eventually. Especially kids just want to go out and they don't warm up, and then they start winging that ball, and it's all downhill from there.
So then do you only take referrals based on pain, or will you do like a preventative referral as far as doing the video analysis?
Well, sometimes we've done it with a bunch of those, the videos that I showed you, except for the last one, were with a travel baseball team. So we went out there, the other Jeff, he screened the kids from a shoulder standpoint, and then I videoed them. I think they were all pain-free, but he ended up a couple of the kids he kind of put an asterisk next to, they ended up seeing him in the clinic because they ended up getting hurt. So the downside of that is I never got to get with their pitching coach to go over those. So yeah, that's it's a great tool for that, I think, from an injury prevention standpoint. Just takes a lot of time. Yeah.
I think that first video you showed, do you see any issues when the pitcher to get to this position opposed to going straight back, or?
That's the biggest issue because they want to keep it, they want to throw it like they want to throw it from their ear.
The new term is like the short arm is the new thing. Is like
Why? Yeah. Yeah.
But as long as they get in this position.
Yeah, because they eventually need to get there.
Right.
Yeah. I just think from that standpoint, and I could be wrong, from an energy efficiency standpoint, if you're here and you're going to eventually get here, right? I don't know. Yeah, I don't know. I'd like to talk to some. We should talk because I'd like to know more about that. Anybody else? I don't see anyone.
Anybody have any questions online? If so, just type them in.
I have a question.
You have to click.
Oh, let me get out of that.
Yeah.
Anybody know what flag that is? Yes. So I just had my DNA done, right? And I was less than 1% Senegal, so I had to give them a little shout out. So I throw that in there.
Make sure if you're from New Jersey with a PT license, make sure you sign out. Make sure if you are any other licensure, make sure you sign in and get scanned. If you're watching online, make sure you click on the My eLearning link that I'll be sending you either today or tomorrow, and then that will be set. And you'll need to take a quiz, and everybody here will also be sent a My eLearning link for a quiz and a feedback form. So thank you very much, and I'll see you next month.
Thank you. Stop.
Yeah.